first. First, we'd like to acknowledge the guests that are here today. So if you brought a guest, would you please wait for a microphone and introduce the guest? Raise your hand. Okay.
I'd like to introduce my guest, Heather Unix. She's a nurse.
Any more guests? Well, I'm going to introduce a guest for Jeff from Lifestyles. Art Villafane is right here. He's from the magazine Lifestyles of the Lehigh Valley. You see that magazine all around. So he's here to check us out. And
hi, I'm introducing myself. Art. This is Art. As Jean said, I'm the editor of Lifestyles Over 50. It's my pleasure to be here with you folks.
And we have another distinguished guest here today, sitting right in front of me. David, I had to put my glasses on because I can't read your name card. David Woods is the coordinator of development services at Lehigh Valley Hospital Network at Pocono, who are going to join. They're going to have a board of associates up there and join with us. So this is Dave, and we welcome him. And while I'm on the subject, we're now in the process of getting ambassadors from Schuylkill to join the board of associates. So we are growing. Brian, you're going to have to get the Agriplex in the fairgrounds for our meeting. Okay, so we recognized everyone that was here, our people. All right, now it's my pleasure to introduce from management, President and Chief Executive Officer, Dr. Brian Nestor.
Thanks very much, Jean. Hear me okay? Stay away from there for the echo. Great to see so many familiar and new faces here. Some recent graduates, recent retirees from LVHN. So a number in the room, but just really great crowd. So happy to have you with us. This is a opportunity for us to kind of give you a quick update, if you can. More new graduates I see in the room as I look around. Great, great. And just give you a little bit of an update on what's happening. You've heard, I think if we reflect over the last 3, 4, 5 years, it's too much negativity, right? Talk about how rough it is out there in healthcare. That hasn't changed, all right? Inside, we talk about how it's going to get worse before it gets worse, and that's true, okay? But that said, that's not going to stop us from doing great things. So, and we continue to grow, we continue to try and meet the demand of our patients that want to have easier access, okay? That's a big part of this. And they want to have a better experience, right? And then behind the scenes, somehow we have to figure out how to do that for more people at higher quality and a lower cost. That's value. I'm going to talk briefly about that. But I think the cool part of today is when I'm done talking, you get to hear from some really awesome people, some incredible providers. When you hear these docs talk to you, just think about how fortunate we are in our community to have this level of talent in the Lehigh Valley. It is actually something that if Leonard Parker Poole were looking down, when he envisioned a superior regional hospital, he would just say, my goodness, this has gone well beyond my dreams. I can't imagine he wouldn't feel that way. And I think, again, the presentation we're going to get, we love to give you a dose of how the network's doing, but we love to give you a better dose of what are the cool things we're doing and what's exciting in the care that we provide to people. And today you're going to hear something really extraordinary about the technology deployed by our surgeons. So really quickly, let me just give you a couple quick updates. The good news is, this is the first time in 4 years that I've said to you, hey, we're making money, okay? We always make money, but our industry always says that you need to have a 3 to 5% operating margin to be able to have enough excess dollars left over to reinvest in your people and the technology necessary to take care of your communities. All right? Healthcare is exceedingly, exceedingly expensive. When you hear what these surgeons are going to talk to you about today, you're going to be amazed at what they can do, but it all costs a lot of money. I tell a little anecdote all the time. In the last 20 years, I've been to a number of galas at different hospitals across the region, and within the last decade, I was at one where the entire gala, philanthropic gala, was to raise enough money to buy a mammogram machine. Okay? So to put that in context, if you or your daughter or mom or cousin or neighbor is getting your care at a place that requires a philanthropic event to buy a mammogram machine, you're doing yourself a disservice. You are not getting the care you deserve. In fact, I would tell you that that is such a joke that even the best of the best of the best organizations out there aren't doing as good a job as they could if they don't have the right relationships. Really quickly, the two surgeons, Dr. Marty Martino, all right, is a gynecologic oncologist, and he's going to talk a little bit about robotic care, all right? We're also going to hear from our chief of urology, Dr. Angelo Bacala, okay, who also, as part of his work, takes care of cancer patients. Now, not in their field, okay, but I want to give you this soundbite. In this community, patients were cared for at other locations, all right, other community hospitals, all right, not us, that now we're in hospice. We have 3 over the last 18 months, end-of-life hospice care that are now disease-free because they got a late second opinion, all right? I won't tell you the disease because you might actually figure out who these people are. But the point of that is, it's not that they weren't cared for by well-intended good doctors or providers. There's good doctors. My point is that things are traveling so fast today, even really good doctors can't keep up with it. We're fortunate to have the relationship with Memorial Sloan Kettering that has 900 clinical trials, 900 plus clinical trials. And by working with, you know, probably the world's best, the global leader in cancer care, we're able to bring those insights to a community. And that community includes Schuylkill, it includes Pocono, it includes Hazleton. All right, so I'm not saying those things to bash other organizations. I'm just saying this is a consequential time in healthcare. And you got to be at a place that is going to make the necessary investments to get there. So back to 3 to 5% operating margin. Hey, man, if you are not making a 3 to 5% operating margin, you're not making the critical investments. If we ever needed those investments, it's now. Because there's a really wonderful view of the world if you have a bad disease, whether it's cancer or cardiac care or some really challenging surgical issue. We have new technologies, new procedures, new trials that can actually help you and maybe save your life. If you're ever going to have a problem, boy, I'm optimistic that we can have a solution for you. And we can have it, keep it in your neighborhood and not have you have to travel to Philadelphia or New York. So I don't want to take any more of their thunder. But we budgeted a 3.3% operating margin this year. We will exceed that by a significant amount. By the way, our 15-year running average prior to the last 3 years, which, as you know, I've been complaining to you that it's challenging and we're trying to make a big turn economically to kind of provide higher quality care to more people at a lower cost. We've made that turn. We've absorbed all those costs. Last year, we made 130,000 contacts to 20,000 people that we know are at high clinical risk, and we gave them better outcomes. All the while, you know what we did? We burned stacks of perverse fee-for-service revenue dollars by keeping people out of the hospital. That's a good thing, right? You don't want to be in here. If we can keep you out, that's the way you want to be cared for. And by the way, wouldn't it be better to have a radical prostatectomy by robot and be discharged in 28 hours as opposed to a 10-day hospital stay and a catheter for 2 weeks? And those are some of the things we're doing now. And by the way, you don't get paid to do all those things anymore, all right? But we're going to do them anyway. We're going to bring those best technologies to everyone. Our focus, though, in the network, I mentioned it briefly, access, experience, and value. We have to improve access to our patients because if things are easier and closer to get to, people tend to get more engaged in their care. If you have to drive 18 miles to get your blood drawn, maybe it's not that important, right? If I have to go 20 minutes and then wait to see a provider, maybe I won't do that. But if there's an Express Care in Fogelsville you can walk into, all right, that we now see hundreds of thousands of patient visits because it's easy, people get engaged. Give you an example of better access. Up in Hazleton, these are just 2 shots. Hazleton, we're transforming the entire hospital into single rooms. Private rooms for everyone. We're going floor by floor by floor. Brand new front entrance to that hospital, doubling the size and capacity of the emergency department, which is a critical need in that community. And what another critical need up in the northern tier here is behavioral health resources. So we will have 5 private behavioral health beds to take care of folks that have either mental illness or behavioral health problems. Cedar Crest, you may have already heard or seen that we're going to be building probably the coolest emergency department in America. And it's unusual. Not only will it have like 90 plus emergency department beds, but it'll also have 60 observation beds. So we can cohort. And on any given day here at this campus, there's 60 or 70 people floating around on different floors that are classified by CMS as an observation case as opposed to an inpatient case. We've talked about that before in terms of what that means economically to you. It's a challenge, right? So we want to cohort those folks in an area that actually can get streamlined service. It's crystal clear that you're an observation case, and we can give you the best possible care and not move you all over the hospital. You can stay right where you were just admitted from in the emergency department. By the way, when that building is done and built off the back campus, everything that you've seen in the acute inpatient ER today will be the children's emergency department. It'll be the biggest children's emergency department probably in eastern Pennsylvania, okay, except for CHOP, all right? But they're a little denser than we are in Philadelphia. All right, so just 2 examples. We have other construction projects that we'll give you an update on later. We also work not to have better health, better care, better cost for our community. We also have gone to the quadruple aim. So the 4th goal is better colleague engagement. We call our employees colleagues. All right, so, and we always believe that employee satisfaction drives patient satisfaction, drives business results. It is hard. Healthcare is really a hard environment to work in. And, keeping people, enthused about the work and keeping them positive despite the challenges of delivering that care is a hard job. But we're working very hard on it. And this past year, evidence of that is we were ranked in the top workplaces. There were only 43 in the region, and we were at the top of that list and very, very proud of that. Also noted to be the top place for training. For folks in the community. So very proud of that. We're doing a lot in that realm to try and improve the environment for our workforce to make sure that we're, we're up to date. Okay? We've expanded all our bereavement policies. We've tried to address some of the social norms, if you will, around what to wear at work and what not to wear. We're a little buttoned up here. But that's just not how the world is anymore. Try and help people with their economic issues. How do we actually have access to cheap insurance for things outside of normal life, dental and health care, and how do we help you save for college? So this is just a short list of about 20 different upgrades we've made to our colleagues over the last year. I forgot. Thank you. Okay, no. This is a video. I was supposed to tee up. I went too fast. So we're going to show you a little video about some of the other exciting things we're doing in the area of cardiology. You're not going to hear about cardiology today, but we want to give you this spot on some good news about access and the type of care we're delivering. Let me see if I do it correctly.
I have 5 grandchildren.
Yay!
Being a grandma to me means everything. I'm a mama, not a grandma. Summertime's the best. We try to look for a new adventure every week to set out to build memories. That's my goal. I brought my grandchildren to the Poconos for the day. We did the water slides. I just didn't feel myself. After I got back to the hotel for the night, the pain in my chest came and then the numbness in my arm. And then that's when I had my daughter call 911. They did an EKG on me. The EKG read normal. It's not going to hurt to get checked. They took me to Lehigh Valley Hospital, Pocono. They confirmed I had a heart attack. As I was waiting in the emergency room, I then had another heart attack. They did a catheter up through my arm, down through my heart with the visual to see. They thought they were going to be able to open it up and stent it, but there was too much blockage that they weren't able to stent. It was no longer an option. So that's when they decided to do the bypass. The first time I met Dr. Wanamaker was Friday for my surgery. I was positive, knowing that they were going to take care of me and do the best that they could, and they did. And I ended up with a quadruple bypass. She saved my life. Lehigh Valley Hospital Pocono is a lifesaver. The staff treated me very well. They are patient, caring, which is very important to me. Everything was explained step by step. I think that's what helped pull me through. It's been 4 months since my bypass. If I didn't go to the hospital when the ambulance was there, I probably would have taken the chance to come home, and then I don't know what would have happened. I'm looking forward to continuing to build memories with my grandchildren. I want them all to have something of me to hold on to. And now I have a second chance.
Nice. We're going to be, I was chatting ahead of time that you're going to be seeing a new branding and marketing approach in the community. Over the last few years, we've been sticking to the knitting of trying to improve care, measure everything, expand our metrics around quality, insert that into all our contracts, make sure that we're getting reimbursed from a value perspective, getting reimbursed for keeping people out of the hospital. It's a very atypical approach. That's not what most other organizations are doing, not what our competitors are doing in the market. They're building new hospitals and expanding the number of beds, and that's not how you take care of a community. The way you take care of a community is you make sure that those assets are in the community where people live, and you expand those services for vulnerable people. A good example of that work today is out in Schuylkill, where we have built a brand new infusion center. By the way, if you want to lose money, build a brand new cancer infusion center, okay? But if you are in the top 5 counties in Pennsylvania with cancer disease burden, that's what you do for the community. Another really good way to lose money is to build a birthing center, a new maternity ward, okay? We did that as one of our first actions, just opened that up. Great way to lose money, especially when 7 out of 10 babies born are on medical assistance in that community, all right? But that's what you do if you take care of a community. When you have top 5 county in the state of Pennsylvania, in Schuylkill County, for cardiac disease, all right, you put cardiologists through telecardiology, and then you put cardiologists in the community. In a community that has an average age of the medical staff is 62 years old. Never seen that in America. Okay, that's old, just in case you didn't know. That's old, okay? Should be 51, okay? So there's a lot of challenges. We attack what's problematic for the community, and we make sure you have those services, not build new hospitals. You will see new buildings with us, but they're going to be very much tailored to what the community actually needs and how we can keep people out of the hospital if they don't have to be there to begin with. Another very cool thing, just to show our connection, just representative of our connection to the community, you may have heard of this Close to Home series. I don't know if you have. If not, we'll try and get you copies of... we did talk about it here? Okay. Close to Home series. This is, we've had 3 already. This is a collaboration with PBS. And it is just fabulous. About 30-minute documentaries on some of the real social ills in our community, by the way, that are dirty secrets in every community. Okay. One is around street medicine. And this is the Emmy that we just won in that collaboration for that documentary. Wonderful relationship with PBS. Channel 39. And then most recently, we just produced the Survivor story, all about human trafficking. Horrific to realize that Allentown is a hotbed for sex trafficking and human trafficking. But it is. We have full-time FBI agents here in this community with full-time homes to take care of women that have been taken out of, the sex trafficking industry. Unfortunately, we are right between New York and Philadelphia. So the highways run right through us. So it's a tough piece to watch, but these are a series of these that we hope will create greater awareness. Depression was another one we did that hides in secrecy sometimes, and we're working on opioid addiction right now too. So very proud of that work. And finally, last slide, we want to let you know about the Wellness Fest that we're having. It's on June 7th and 8th. It's going to be over at Muhlenberg. A lot of cool demonstrations, a lot of opportunity to check out how your health is and have a little bit of fun at the same time. So with that, I'm done with my comments. The state of the health network is solid, and it's always nice to be in a good financial position. And again, I don't think we have to make 4 or 5% operating margins. Could we do it? Absolutely. We could make 7, 8% operating margins, but we wouldn't be providing the services that our community says they need. To show you some of those unique services, I'm going to hand this over now to Marty and Dr. Bacala. Guys, you want to step up and get going? Again, as you listen to this, and I don't want their heads to get too big, but just wonder, why do we have these guys in our community? Aren't we lucky? That's how I feel about it. Thank you.
Thank you, Dr. Nestor. And thank you very much.
And you aren't going to entertain any questions?
No, I think we're going to go, and at the end maybe we will.
I guess I should be introducing. I dropped the order up for you, but you don't want to let that screen down.
That's okay. Thank you.
Okay, were there any questions for Dr. Nestor? You got a featured spot on that video, didn't you? I didn't even know that. Okay.
One question there.
We have questions here.
One question.
My question is, several years ago when we decided to form an association with the University from Florida with the idea that graduates possibly will stay and practice here in Lehigh Valley, is there any update on how successful the program is?
Yes, and it isn't as successful as we would like. It's still a little bit early, okay? But we've now had, I think, graduated our 5th class, I think, 4th or 5th class. And we have, on average, probably anywhere as low as 3 to as many as 6 that stay. Now, keep in mind, this is a 4-year medical school experience. The last 2 years they spend, for those of you who don't know, it's University of South Florida is our academic affiliate, and they do the first 2 years in Tampa, the last 2 years they do here. So right now we have 100 students somewhere running around the place that are getting trained. At the end of those 4 years, they apply for their residency position, and that's really where the question is right now. One of the reasons to do this, and we call it the SELECT program, and that's to train doctors a different way, to be team members as opposed to be captain of the ship like we were trained. It's great to have a captain of the ship. You want to have a captain on the ship, but you actually have to learn how to work with the rest of the people on the team and have the humility to know that your outcomes are only as good as the team you work with. Okay, and we always say here the foundation of that is extraordinary nursing, and they're just part of the care team, right? So we thought instead of trying to go through this really rugged behavioral interviewing process, which we still do anyway, and last year we hired 300 new doctors and advanced practice clinicians, and we're on track to do it again this year, that we should start to grow our own. Let's train them in this team-based care. And so we have about, our experience in this 4 to 5 year period is only about 3 to 6 that match and stay with us. Here's the problem. Many of them are matching at Mayo Clinic, Cleveland Clinic, Mass General. I mean, the darn program's good. And they're going great places, okay? We think, though, and by the way, we just actually have 2 or 3 family practice folks that are completing training that are going to be starting here. So we are growing seeds and growing new ones. Probably not as robust as we would have liked, but the thinking now is that people will go home like kids, right? They will go away, and then they may come home. So after they go and do their residency training in orthopedics or in cardiology or internal medicine, that they may say, and now I'm going to go back to that place I really enjoyed living. So we probably need about a decade to figure this out. And we are growing them, and they are coming back, but not as robust as maybe we would have liked initially. Thanks for the question.
Dr. Nestor, I'm not too sure if I heard this correctly, but I think you said at Hazleton only 3 to 5 behavioral health beds. To me, that seems small. And how was that determined? And maybe I heard it incorrectly.
No, you heard it right. It's 5 dedicated behavioral health beds out of an emergency department of 30 plus beds. Okay, so actually, that's a lot. Yeah. So, for example, at Muhlenberg, back when we first did this, and we kind of bucked the trend back in 2000, we actually, Annie Pennick is here, who was the director of the emergency department at the time with me. We had roughly 30 beds in the emergency department, actually just under that. And we were seeing about 40 patients a month that had a mental illness diagnosis or behavioral health issue. And that's out of, 200 patients a month, okay? 200 patients a day, and we were only seeing about 40 a month, okay? That's normal for a community hospital, okay? So Hazleton's probably seeing 40 to 80, in a month, okay, that have real deal problems that need to have isolation, all right? We actually started, when we concentrated all the psych services on the Muhlenberg campus from across the region, we went from 40 to 240 in 1 month, and it overran us, all right? We handled that additional volume with 6 beds, all right? We built a brand new 6-bed unit, and that was fantastic. Better for patients. We reduced our need for chemical restraints and physical restraints almost to zero. Better environment for everybody. So 5 beds, I think, is a very robust investment in Hazleton. It'll change care there. Yeah. Thanks.
Thank you, Dr. Nestor. Now it's my privilege to introduce our featured presenters, Dr. Angelo Bacala. Did I say that right? And Dr. Marty Martino. Their bios are on the back of your agenda. So if I had read all this, it would have gone into the time for them speaking. This way we have more time for them to speak. So you can read that when you get home or while you're listening to them.
Thank you. Thank you.
Who goes first?
We're going to present together. So thank you very much for the kind introduction, and thanks to everyone as well. Can you hear me now? Can you guys hear me okay? All right. Thank you for that kind introduction. I want you to sit back and imagine a world that's different. Imagine a world where you can have major surgery done, major surgery and a minor recovery. Think about that. You can have a big problem, whether it's a cancer in your prostate, a cancer in the uterus, in the lung, and a minor recovery. Well, we've been imagining that world over the past decade, and thanks to our teamwork here and collaborative experiences, we've been able to deliver that, and that's what we're going to talk about today. So with that said, Angela and I here to really present to you on our technology. And he and I have lived this technology. We live this every day, as you'll start to see. Imagine a world with no more cancer. And this is a little introduction to lung cancer where you can see a tumor that's in this patient's lung. And today we have technology that we're able to identify it, biopsy it, and eventually ablate it or resect it robotically. And Dr. Richard Chang is one of our surgeons here, or Rob Kruklitis, that's able to help us with that. Well, what were these guys imagining? Right? Who knows who these two guys are? The Wright brothers, right? So they were trying to imagine and figure out, how are they going to fly a plane? That sort of started years ago. And then this guy, who knows this? Lindbergh, right? He too had to figure out a problem. How are you going to fly across the country, or actually across the country and then across the Atlantic Ocean? And he did that, and he flew to Paris in 1927. Took 33 and a half hours to do that. But he solved the problem, and now, of course, we can fly all around the world. But that's sort of an example of those Wright brothers. So we're kind of thinking, we're these two guys trying to figure out how are we going to fly together? And we do every day as we sort of try and take our ship, and we tell our patients when we do surgery, our job is to be your pilots and take the plane, and we're going to help with our team guide you through the clouds. We're going to have some ups and downs, but we're going to land that plane. And we're going to land it, so you're going to have a minor recovery, even though you had a major surgery. So keep that in mind. And this is today, of course, what you know. Who would want to fly in this old 1927 cockpit? Well, this is what Lindbergh flied in, looking through a periscope with rudders for 33 and a half hours. Or do you want your pilot to be in this plane or that plane? Well, it didn't take our network long to realize that we should have the most advanced technology flying as opposed to flying 33 and a half hours. And as you'll see, we're the only network in the region that has 10 robots here to care for our community. 10. The largest far and away in the region. So how did this start? Well, this all started with a dream, right? There's a little voice on this.
In an effort to make laparoscopic procedures as natural for a surgeon to perform as open procedures, SRI International is developing the Telepresence Surgery System, a remote manipulation system that incorporates the advantages of both minimally invasive and open procedures.
The surgeon would sit at a console like this, would put on a pair of glasses like this, and look in and see a real three-dimensional world, and would grasp an instrument that feels like a surgical instrument, reach into this world, and begin to manipulate objects in it.
So that's how it started, with just a dream, and that was many years ago. Well, today now what we have, all right, is this newer technology. And I'm just going to show you, these are tools. These are all our tools. It's the surgeon that does the surgery, not the robot, all right, the surgeon. These are tools that we use every day, our stethoscopes, thankfully, to listen to our heart and lungs and examine our patients. But these are tools. That's all they are. This is a straight laparoscopic instrument, and this is a robotic instrument that we're going to pass around. But I'm going to let Angelo tell you back, this is what we used to do several years ago, and some of our colleagues do, but we've been evolving now to a newer surgery, the robotic surgery.
So when you watch that video, you see this amazing idea, right? It's all in black and white. This is what we're going to do. And people are thinking this is, no way this is ever going to happen. Kind of like a lot of the things we see now. The difference is that it has happened, and it has gotten progressively better as we move along. And as Dr. Nestor mentioned, the speed at which things are changing now is extremely fast. So they made these big strides. It took a long time. Now we're getting better and better and better as we move along, and we're getting access to better instruments, better tools. And, obviously it's important that we're with a network that is investing in that so that we can bring that to our community. This started with the idea of doing laparoscopy. So laparoscopy means that we are standing at the patient bedside, and we basically redo open surgery. But instead of doing, and we do it the exact same way as open surgery, except we're using tools and standing outside the body and letting the tools work inside. So we put ports in, these little round metal little devices that go into the abdomen, and we put the tools through those cannulas, is what we call them. And the instruments get moved in and out so that they don't cause trauma to the tissue, but once they're inside, we manipulate them and we look at a TV screen. That TV screen is like the TV screen you have at home. It's a 2D, we have some people have 3D screens, but most of the time it's a 2D screen that you're looking at home. Very efficient, wonderful surgery, completely changed how we're doing these cases, right? So now we're standing outside the body, small instruments, small recovery, small incisions. Wonderful. So then things got better. Then we looked at doing robotic surgery. So robotic surgery is taking laparoscopy and moving it to the next level. So basically what's happening now is we still have those ports, we have instruments going in, but instead of us standing at the bedside and holding those instruments, we're actually sitting at a console that is a little bit just off the side of the patient, and we're manipulating those instruments. So we are still doing the surgery, but the difference is number one, we're looking into a console that is now in 3D. So we feel like we're literally inside the abdomen operating. So it's a totally different way of doing things than staring at a TV screen and working. In addition to that, the instruments are much smaller, and we can get into very, very tiny spaces and do major surgery, as Marty had mentioned earlier, with much smaller scars and minimal recovery. So this is sort of how robotic surgery works. We connect the table, right? So you have the table here, where the patient would be on, the actual robotic instrument here, and then aside from that, a little bit of ways, is a console that we would sit at. And we would control this robot and control its arms and maneuver how things are happening inside the body. The other thing that we have is we have different instruments. So as the robot changed and went from generation 1 to generation 2, the types of instruments that we were allowed to use got better, got more sophisticated, so we were able to do more complex surgeries because we had better tools, as Marty had mentioned before, and some of those are being passed around now. You'll see the ones with the blue, I don't know where they are right now, but the ones with the blue arm on them, those are the robotic tools, and they go in and out of the robot right there, yep. They go in and out of the robot, and those tools are controlled by us at the console.
And they're all connected by a cable for now. It's 166 feet. But realize now 5G is coming. 5G is the future, and 6G at some point as well. But 5G for sure, and our Koreans have already, the Koreans and the Chinese have now demonstrated that you can do remote surgery 30 to 50 miles on 5G without a cable. So the technology's there, it's been presented. The companies are being built, as we'll show you at the end. So the future is going to, the next 10 years, I'm not sure what we're going to be operating with, but we're going to be here doing it, and we're looking forward to caring for our community. So.
And when you think about what that means for our community, we can be in one location, you can have surgeon expertise in one spot, but be able to still bring that same level and that quality to faraway places. You know, even outside of our community, when you think about, in the battlefield, and people need operations, this is where this technology is going, that, it can be done from a safer location and still be done on patients. Very, very neat stuff. So some of the things that we just talked about, the 3D vision, this is sitting inside the console, and if you get to look in there, literally, you get depth perception while you're operating. Wristed instruments. So if you look at those instruments that are being passed around, at the very end, the instruments can move, and they can actually flip 360 degrees. So think about that versus laparoscopy, which we talked about before. We were standing at the bedside. My hand can't turn 360 degrees. Nobody can. But we can do that now with these instruments. And that allows us to get into smaller spaces and get more precise in our operations. In addition to that, you can see how small the size is. How small the size is of these instruments, and again, it helps with the types of operations we can do. It's increasing what we can accomplish. So these are the different models of the Da Vinci. As I mentioned, as it started out, brand new technology, very unique, very different, and as time went on, we started seeing not only did these change, but the rate at which they came was happening very fast. And we have, at Lehigh Valley, progressed through all of these. The Da Vinci S in 2006, the SI. And again, these things got better with things like the fiber optics and the camera that we're using. We can see much more clearer. The instruments that are allowed got different, and they were changed for us so that now we could operate now with different tools, that we could do more types of surgery. And then the latest that we had, up until just recently, is the XI. And the XI really brought a lot of new different things for us. In addition to the different tools and things that we can use, we also use something called Firefly technology. And this is where we basically inject, and Marty's going to talk about this a little bit later, but we inject a chemical, and we can use it, for instance, when I'm doing a partial nephrectomy, where I'm taking out part of a tumor in a kidney, I can differentiate between tumor and normal tissue. So it helps to make sure that we're sparing as much normal tissue as possible, but still making sure that we're doing a good oncologic cancer case and removing the tumor. So the latest version of this that has just come out is the Da Vinci SP robotic system. So this stands for single port. And we are one of only 15 hospitals in the world that have this technology. And it's coming right here to Lehigh Valley. And this is the latest and the greatest. So we went from great to better. This technology is very different. It looks a little similar. It has a tower. It has the console that we sit at. But I'm going to go through and explain a little bit of the difference. The biggest and the most obvious thing is when you look back at this and you see all these arms, that's not the case here. Where's it going? It's only one arm, and there's just one port now. So instead of putting in, as I mentioned before, all those ports that go in and all the different instruments going into each of the different ports, now the camera and the 3 instruments are all going through one small port. And the way that they get around making that happen is that the instrument arms are actually not only wristed, but they're also flexed at the elbow. So they go in straight and they kind of come out like this. So now we're working in the abdomen and being able to operate through a small incision that then we can maneuver the instruments out and actually do all sorts of great cases. Small little instruments, fantastic surgery, but through one incision now. So even when you think about mobility, right? So what's the difference behind having something that has 4 arms but having 1? Think about that robot moving, right? So if I'm going to look right and my instruments are stuck in the patient through the cannula, if I look right, everything's going to have to slant like this, right? So you lose some mobility of this hand, you lose some mobility of this hand, right? All different now. Now, when we go in and we look, we can look to the right, all the instruments move together. And I have all the same maneuverability that I had before. And what's more is that now I can only move so far because we're going to be limited by the movement of the robot before. Now we can actually look 360 degrees in the abdomen. So this opens up all different types of surgeries that we could potentially do. Through one incision, we can hit all different areas of the abdominal cavity or even in the chest when it's used up there. And so it really has been a great game changer. So, you know, I titled this From Great to Latest and Greatest because you can see, and we have a good video on this, I think. Is that attached to this, or when is that video coming up? The single port video? Is that? Want to show it? Yeah, yeah. Okay. So I think, yeah, go ahead. So this is a little video on the single port, and it'll show you the different arms and things that we can do and use. It's not coming up.
Can't get this. Oh, excuse me. Sorry?
Hey, that's all right.
Please hold. What do I have to do?
I'll just drag it over. There you go.
Scroll back to it.
Go back up. There it is.
No, right here. There we go.
There.
Perfect.
Almost looks like a spider. Think of that spider starting to open up. Like Angela said, it's starting to be able to operate. Incredible optics. 360 degrees turning all through one little port.
See how it rotates and moves, right? All the way around. You can look anywhere in the body with this. So clearly, you know, pretty cool stuff. And I mean, I do this, and I still, you know, I get excited when I see it, right? Because it's neat, it's new, it's different, and it really, really changes the game of how we operate and how we do things and where we can go and what we can offer our patients and the type of procedures we can do. And again, we're one of 15. That's it, right? So, you know, I trained at the Cleveland Clinic, I called up Cleveland Clinic. These guys just got it. And I was like, hey, you know what? We're getting it too. We're getting it in a couple of weeks. How are you guys using it? We can discuss and collaborate together on this new technology and where it's going and the different types of operations we can do. Dr. Nestor mentioned changing, doing a prostatectomy and going home within 23 hours. This may change this completely for us. We're looking at potentially sending patients home the same day because we may be able to access the prostate from outside of the abdominal cavity in an area of a space that is very, very, very small, but that we can actually get into outside of the cavity where all the abdominal contents exist and still get to the prostate and remove it, in which case the patient's recovery is going to be that much faster. So we're providing those benefits to our community from doing this, and Lehigh Valley is obviously investing in this. This looks at some of the different features of it. I'm going to move through this relatively quickly so I can get back. I know Marty's got several other slides. The flexed arm that you saw there, you can look with the camera straight, 0 degrees, 30 degrees down, 30 degrees up, all in one spot. The arms are flexed. You can maneuver and manipulate the tissue. From inside the console, you can see this is what it would look like. You can change your view from inside the console, looking at a front view from a side view, and this is an animated picture of what the tissue would look like and how the instruments would look. Very similar to how we do robotic surgery now. It's not different, except it's going to change things for patients and make it better. Within the console that sits right here, which is where our arms would rest, we would put our fingers inside of here and maneuver the instruments within here, and our elbows rest here, and we sit in a chair with our feet down here, where our head then goes in here and we look into the console, okay? At that point, we can change things on the console, like our energy settings, we have totally different setting panels. All this is new, all at our fingertips. Our foot pedals, they've all been a little bit changed. It's added some features and functions for us so that we can, again, with just a push of a button, we can actually maneuver the camera all the way around and look around inside the body. So some of the benefits, just to recap of this, it's a surgical platform with a single port and enhanced optics with wristed and advanced instrumentation. And again, it kind of comes out, kind of like Marty said, like a little spider. It's possible to control more through narrow spaces with triangulation at the tip of a flexible Da Vinci camera. And again, this is what I was mentioning before about maybe even changing the operation to make it even better for the patient, like we're planning on potentially doing with a prostatectomy. We have a 360-degree view, and we can move anywhere because the boom sits on top of the patient and rotates around them. And it opens up more surgical possibilities for us. We can control more through these narrow spaces, through both the camera as well as the instruments, and we can reach anywhere with that 360-degree access with the boom as well as the port. So I'm going to turn it over to Marty, and he's going to go and talk a little bit more about the growth of our program and where it's been.
Thanks, Angelo. So imagine that, right? And as we're sitting here thinking, this is FDA approved today, the SP for urology and head and neck. Now we have 11 service lines, and we're imagining where else we'll be able to use that. This will be able to be used for gastrointestinal procedures, most likely, where there could be small tumors in the colon or the rectum, ENT already, lung, gynecology. I've got our 2 residents in the back, Chi-Chi and Alexa, listening, and they're probably saying, when can we get access to this as well? It's absolutely coming. As our program's grown, though, this is the landscape in 2001, right? And there really was no significant robotics being used back then. I will say that St. Luke's did have the first one, and they left that one pretty much sitting and didn't use it too much. In 02, you can see this is a heat map slide, and you can see some cases being done. And really over here, as the market's grown to 05, you can see here, this is the blue looking at where things are done. And then 2008, LVHN started. And we started our program here, and this is now pink in 2012. Pink is gynecology, blue. Far and away, we started to grow our procedures, our teams, our surgeries that we would do. And you can see nationally as well. But look what the pink has done, right? As time's gone on, you can start to see we have the largest program in the state of Pennsylvania. This is the largest program in the state doing gynecologic surgery as well as a lot of other procedures. And moving forward, this has grown as we've adopted and increased our hospitals as well to our community. So really, if you're a patient looking for surgery, there's nowhere else to come than here. And I've heard Dr. Nestor say that multiple different ways. But he's right. He's absolutely right. We sit there in the clinic, and I see patients. They come in. The other day, we see them on Facebook. Can you see, someone from New Jersey, New York? Sure. Send them in. Why would you go anywhere else? Why would you think about it? Why? We have invested in this technology, and we will continue to invest. Every year, it seems, Brian, that we're going to the board, and you'd ask for a new platform, so prepare for next year. We're ready. They're ready. Right? There's lung robots coming. There's GI robots coming. We are ready. Now, here's our current state. And I will say we're just about approaching our 15,000th case. 15,000 cases as a team. It's not one person. It's a whole team that are urology and gynecology, which really, urology and gynec started this here at 17th and then Cedar Crest. And now we've grown to have multiple specialties across with multiple outstanding colleagues that we get to work with to be able to work together. And if there's a challenging case that one of our team members are in, they'll call us. Angela will call me, or I'll call him. We're all now able to assimilate and use this technology. Years ago, if one surgeon's not trained, sorry, Aaron, we're going to have to open you. You're going to have a large laparotomy. That doesn't happen here. In fact, we do our best to avoid a big incision because we're looking for a minor recovery. We believe we can do that. This is our 10,000th case that we did as well. And we'll see if we have a cake for our 15,000th. But this is back then. Thinking about the Better Care platform, better quality, better cost, better experience, our Better Care pathway has significantly improved with the Firefly that Angela was speaking of. And it was due to our partnership with Sloan Kettering where this was pioneered. We went there to learn it, to see how it's done. And we learned less is more. So Firefly is a technology where we can use an ICG type of inert molecule to inject either IV that you may use for prostate, for radical nephrectomies, for kidney surgery. And what does that allow you to do when you do it for kidney?
So when you do it for a kidney, what happens is it is selectively taken up by normal kidney tissue and not so much by cancer. So what we typically tend to do is we stop the blood supply temporarily to the kidney, because if you cut into a kidney, it's just going to bleed profusely. So what happens is when we stop that blood supply, after we give the injection, the kidney itself lights up, it turns green, but the tumor tends to not be as green. And so there's a difference. And so we can actually, with the toggle of a foot pedal, we can go between regular light and the light that allows us to see this green and non-green area. So what happens for us then is, after that injection is given, within a minute or two, we put the clamps on the kidney, stop the blood supply because the blood has already gone to the kidney, toggle back and forth, and as we're cutting, I can see where tumor is, where normal tissue is, stay right on the edge of that tumor, take out the tumor, and leave the normal kidney behind. The idea behind this whole process, right, if it's a partial nephrectomy, is you want to keep as much of the normal kidney around as possible. That's the whole idea. Because there's other things that can affect your kidney as you get older and have other medical issues. So this allows us to really preserve as much kidney function. The other thing is, we want to get the clamps off of the kidney, right? Think about it this way. You put a rubber band around your finger, you can't keep it there for too long or else the tip of your finger is going to die. Same concept. If we're stopping the blood supply to that kidney, it's going to die if we do it too long. By keeping this type of technology, we can go very, very quickly, remove the tumor, put everything back together, get those clamps off the kidney, and preserve normal function, get regular blood flow back to the rest of the kidney as quickly as possible. We actually turn a timer on in the OR because we want to make it under 30 minutes. This type of technology can drop it down to 10, 15 minutes, and we can be off and get the clamps off. So.
Thank you. So what we hear now is 3D surgery that we're able to see. It's why we wear glasses or contacts, to be able to see better. And I will tell you, when we put our surgeon in the console, they usually say, "Wow, I can see better." I say, "Thanks for that, because that's why we're going to put you in more consoles." Now that's one. So 3D guided surgery. We have image guided surgery, what you're hearing here, and the wristed articulation of the instruments. This is an example of where we move to lymph nodes. We now can get margins with this, is what we're describing for cancer. This is a patient now who we're going to show a video of a patient with uterine cancer with a tumor inside the uterus. And that could be anywhere in these nodes. Well, it turns out that the first node is known as the sentinel node. Okay, that's the first node in the channel. And if we can find that lymph node, and if that node's negative, there's a 99% chance The rest of the nodes are negative. That's called the negative predictive value. So when we look at that, we want to find that one node or two nodes on each side. So we've been doing this now for at least 5 years, and let's see if this video plays. And here's an example. Put the lights down, thanks. This is as you see the right hand and my left hand, and we're looking for that lymph node. And there's the flick that Dr. Bacala talked about, toggling, and that's the channel. And there's the node. Now that happens to be a large vein, the iliac vein that I'm operating next to, as well as an artery. But it looks like it's a mile away in 3D. Here it looks real close. But honestly, it looks like it's a mile away because it's precise, it's accurate, and it's exactly where we want it to be. So if I remove that node, we're able to hopefully, we have the lights on, please. We'll be able to minimize lymphedema, minimize complications, which is why we do that. All right, we're going to shift to cancer screening, just as a reminder, okay, for cancer screening. Okay, it's important to bring a friend to screening. Bring them here to LVHN, okay, to stay healthy. Why? Because now there's 4 different ways that we can screen for cancers. Breast cancer, we have mobile mammographies. We have mammographies that are here, all right? We have colon cancer screening as well, and guidelines for that. We have gynecologic, so pap smears, but the latest is lung cancer. Lung cancer, far and away, when you see this slide that's a little small, the most common cause of death is lung cancer. But at LVHN, we're changing that. We are looking to find these tumors smaller through CT screening. So if you have a smoking history, 30-pack years or more, all right, which will be 15 years with 2 packs a day, which unfortunately a lot of people have. And I think secondhand smoke too, we should be looking at that. But right now it's covered by Medicare as well. This is covered for CT low-dose screen. We're able to do that and look for a nodule, ages 54 up to 80. All right, we're looking at that, and that can significantly improve survival. So that's what we're doing now. Those are the 4 ways to think about that, and that's how you can really make a difference. Here's the recommendations: breast, cervical, colon, and lung, just to keep all that in mind. All right, take that home and bring a friend. So detecting lung cancer early, this is the newest soon-to-come robot. Just to prepare you for next year, Dr. Nestor and our team. Okay, this robot is a lung cancer robot. Okay, and there's 73 robots out there today, by the way, that are in development. All right, 73, but I will tell you, not all approved. But this is for lung. Patient here, tumor in the lung. How are we going to remove that? Well, Intuitive has been working on this robot. This is called the Ion, a small, flexible catheter that our interventional pulmonologists or cardiothoracic surgeons will be able to use image-guided surgery and guide this to the end area where the tumor is. They can see it now robotically, do a biopsy, find that it's cancer, and then go ahead and ablate it and remove it. So that's another robot that we're looking at. To do all this, requires a team to standardize practices. And one that we've done, we've actually developed here as well elsewhere at Duke and Cleveland Clinic and Mayo, the Robotic Training Network, to standardize education and training for our residents, our fellows, and a lot of our attendings. We've partnered with the Institute for Surgical Excellence to be able to develop what's known as the fundamentals of robotic surgery to try and standardize our surgical outcomes, to minimize variability and have this benchmarked. And there's an app you can take home for your kids or grandkids. It's free. It's on the iTunes store that we made in robotic surgery, freely available. So this is just a little information to show what fundamentals of FRS is. The future state of robotics, though, is really, really exciting and bright. Why? Because this is where we were in 2008. 2017, we've got a lot more specialties, and it's predicted there'll be 1/3 of all procedures done robotics, looking at in fact, one of our new pediatric surgeons, Sarah, just asked me yesterday, do you think we can come in and maybe think about this? I said, sure we can. So I don't think it's too far along in peds, but we will see. I will tell you some other surgeries in spine and orthopedics as well that we're looking at, and certainly cardiac and vascular. These are currently approved systems. There's even one for hair transplant, restoration robotics, that's available. And you can see spine and others. These are what's in the pipeline. So this is what's really exciting now. Google and J&J have a partnership, and they formed Verve Surgical. They actually recently just acquired Auris Health, which is another lung robot. So now underneath the J&J platform, there's the Verb, there's Auris, which is another lung robot, and they've got the data analytics minds with Google behind it. So this is in development, nothing's released. The thought is 2020, 2021, this, as well as this, may be coming as well. So we're waiting to see how this industry changes. Now, there's a lot of other people that are looking at this, right? Artificial intelligence is out there. Okay, we can tell you that, we know Amazon is out there, right? They want our video. They're developing machines to do this surgery. They actually have, between Microsoft and CSAT's a lot of video that they're trying to develop these machines to do machine learning or benchmark surgeons to help us to do a better job. So that's out there. We're not sure where this is going to go, but I can tell you it's digital remote. We're building the operating rooms to do that. LVHN will be there to lead the way to do this, and you really have to really think twice before you go anywhere else because we've got that team here. This is the word to spread. This is the message, okay? Major surgery with a minor recovery right here at the Lehigh Valley Institute for Surgical Excellence, far and away. We're really, really thankful that you give us the opportunity. And Angela and I are here for any questions you may have.
Thank you, guys.
Thank you. I realize you're both surgeons, but, and I'm back with Pac-Man. I think this is wonderful. But anyway, and I never could get it through there. But I was wondering, sometimes medically a tumor is too large to do anything with surgically. And yet you have this technology that lights up where a tumor is. Is there a way that medically you can inject directly into the tumor to shrink the tumor to get ready for the surgery? Or
yeah, so that's known as neoadjuvant chemotherapy. So we actually do that in ovarian cancer when the tumor may be stage 3, stage 4 in the liver or the lungs. We'll provide chemotherapy into the IV for patients. That will shrink the tumor, and then we'll be able to go and remove it either through an open incision or a minimally invasive approach. In breast cancer, they also do that as well, to do neoadjuvant chemotherapy directly into the tumor. Sometimes we'll do that to look for margins. And some of our radiation oncologists may do some work as well with that. We had a question here on the sticker price of the platform, of the system. When we first presented this, actually Carol was here, and she's helped us with a lot of our technology and slides. We had an LPS presentation, and Bob Wood was here, and he said, "How many of these do you need?" And he sat right over there. And he's raised his head, said, "How many more?" Well, first, how much are they? Back then, they were about $1.5 million. Now they're about $2.25 million per platform. "How many do you need?" I said, "We'll probably need about 10. I'm not sure." And then, of course, I was waiting for him to say, "Well, we're here." But bless his heart, he got us started thinking about that. So we're going to need more. We're going to need more because from what we currently have, we see them as continuing to allow us to provide that better care, better quality, and lower cost. Because now patients are not being admitted. They're going home with their family, back and having recovery. So thank you for the question. Yes.
I have a question. Are there instances where you have gone in robotically and found a surprise, or been surprised by something, and then do you have other options? Do you then open up the patient manually like you would have in the past?
Yeah, sure, absolutely. That always happens, whether you're doing robotic surgery or open surgery. That's the nice thing about having a full team, because if you do go in and you find something, whether the cancer spread further than you had thought, it's into studying of tumor in other areas. That may be the time to then back out and go to medical treatment to try to shrink the tumor. And that's where we can call in our medical oncology colleagues, let them know what we saw. We can biopsy that stuff when we're in there, make sure that is in fact what we're dealing with, have the pathologist look at it right away and decide that. If it looks just bigger or something else that's different. I have to say, with the robotic technology, we can really redo most of the open surgery that we do. It's very little that we have to actually convert from robotic to open. Not because there's any problem with doing that. It's no issue to do it. But there's just not a need as often. But if there ever was, the good news is that we are trained in doing both. And that's the other important thing. We've gotten, sometimes people ask, do you guys, insist that everybody do your cases open? I can tell you right now, no. I do a lot of my cases, or excuse me, do it robotically. I do a lot of my cases open. It all depends. Depends on the nature of the tumor, where it's located, how successful it's going to be, depending on how we're going to access it. So there are clear indications for doing cases open versus doing them robotically. And depending on the tumor type and what type of tissue you're dealing with, all those things go into that discussion. But it's never that, we just do it one way or the other. It's really up, you need to make sure you're comfortable with the surgeon who's doing your case. They have to be well trained in being able to do it both ways and be comfortable knowing how to deal with all those different situations. And that's the advantage of being here. We have that.
And the robot's a tool in the toolbox. So you want to have a surgeon that has the repertoire of the newest tools in the toolbox. It's just a tool. It still is a surgeon doing the surgery. So, that's one of the things to always remember with our surgeons. A number of them are now have this repertoire in their toolbox. So, yes.
I'm curious about.
Do you have more problems with adhesions with robotic surgery or less? And also, infection-wise, do you have better results with robotic surgery?
I can answer that. I'll tell you that we measure our outcomes, and we can tell you that to speak to the infection. When we went from laparoscopy to robotic surgery, far and away, we saw over 50% less infection. We saw 90% less blood transfusion. Our conversion rates, just like he said, laparoscopic 2D straight sticks conversion rates, meaning starting one way, going to open, we were about 20 to 30%. Right now, we're about 1 to 2%. When we start, it's very, very unlikely. So there's less infection far and away, far and away. The second thing was adhesions. The most common cause of adhesions, you can ask our residents back there, but we'll tell you, is putting hands in with the gloves in, doing open surgery. So just being able to go in robotically, there's going to be less. There still may be some, but significantly less.
Hi. Oh, I'm sorry.
Yes.
Oh, I was just wondering about your training. Like, where did you learn how to do all this and such new technology?
So, I'll jump in. So, each sort of surgical specialty is a little bit different. In urology, we train throughout our residency program on the robot. So, when I started, it's a 6-year program. All 6 years, we trained on this. I then did a fellowship in urologic oncology where I just did cancer cases, and I did another 2 years of training. So, we kind of come out of training learning how to do that. And not only learning how to do it, but we know how to do it well when we're done. And there are some programs that do things a little bit differently. Some people do fellowships if they may not have had it in their residency. They do a fellowship in it and learn and kind of concentrate on that area. But that's typically where most people get their training from. But it's very important to make sure that the surgeon you go to does have the proper training. And that's one of the things I know Marty kind of touched on a little bit. We sort of make, we make sure we have a whole program, and you want to speak about this a little bit more, a whole program for our doctors who do these cases to make sure that they are trained, and not only them, remember, it's very important that the team is trained, right? Because your outcome is not just based on what we're doing at the console, it's what the whole team is doing in the operating room. And that has all been vetted and set up.
Yeah. We are part of the Robotic Training Network, again, that we started here and with Duke. And our residents are able to go through a defined curriculum. One of the unique things that we have is we have what's called a patient safety test, that we do not let our surgeons or any of our residents, no one sits on that console unless they pass this test in the dry lab. That's unique here. There's not many places that they're doing that, but there's a test they have to do. And our surgeons have to be simulated, just so we try and take that pilot analogy. We have simulation embedded in our credentialing. They have to do credentialing every year and demonstrate that their skills are still there. And as long as their skills are benchmarked and they're well measured, then they can continue to fly. So we've got these measures in place that we do.
All right, we are a little bit over time, so I think we're going to close the formal Q&A. Thank you so much, Dr. Bacala and Dr. Martino.
Thank you.
Look at the picture.
I knew
oh, my God. You guys, you know what?
Oh, yes, fine.
Are you gonna answer a question?
Yeah, we're here.
Oh,
yeah, so the OR
I have to tell you something, people. I thought the 5-year-old neighbor of mine who taught me how to program my VCR was smart. That little 5-year-old grew up to be these guys. That was mind-blowing. Absolutely mind-blowing. Anyhow, thank you so much. So if you enjoyed our guests, the guests that were here today, if you enjoyed our presentation and you have an interest in becoming a member of the Board of Associates, please complete an invitation for general membership at the registration table. Now, our next meeting, now this is important for the new people that came in this past year. Our next meeting on June the 13th is a Thursday, and it's in the evening from 5:30 to 7:30. So along with having what you have today, an hour, well, a little bit over today, but it was very interesting, an hour meeting with lunch, you're going to have the same thing with some speakers, but then you're going to have an additional hour to interact with all the people on the Board of Associates. So that's our social mixer, and that's June 13th. So we look forward to you coming there to that. Thank you. Welcome. And we're so happy that Pocono is here, and we're going to have Schuylkill pretty soon. So welcome to everybody, and have a good day.
High conflict, that's all.
Thank you again. Thanks for coming. Both of them are doing really well. Only place to go. I was getting my other brother is in
It was an absolute pleasure meeting you. I thank you for